Bienvenidos a este área 4 de ARI 2022, en nuestro 20 aniversario, que va a versar sobre cirugía refractiva, uno de los asuntos troncales de esta reunión. Quiero agradecer a mi querido compañero y amigo de tantos años, Miguel Maldonado, que va a estar con nosotros codirigiendo esta sesión, en la cual va a haber oradores de mucha relevancia a nivel nacional e internacional, y que se centrará en las dos sesiones que vamos a hacer a continuación en uno de los santos griales que tenemos en medicina y en cirugía particular refractiva, que es la solución de la presbicia, para después entrar en la sesión 8 en lo que es ahora mismo la cirugía refractiva, en un momento de transición social y además tecnológica. Por tanto, voy a dejar la palabra a Miguel Maldonado, que va a introducir la sesión séptima, que va a venir inmediatamente después y a continuación. Miguel.
Buenas tardes, muchas gracias por la invitación a estar aquí esta tarde, al profesor Alío y a todo su equipo. Vamos a tener una serie de participaciones que incluyen al doctor George Waring, a Francesco Carones, al doctor Ramón Ruiz Mesa y a Marguerite MacDonald. Y todo ello va a estar modulado por unos panelistas de lujo. Son personas muy expertas en cirugía refractiva, como son el doctor Daniel Elíes, Federico Alonso, Ramón Ruiz Mesa y el doctor Teus. Sin duda, la cirugía refractiva es la cirugía oftalmológica funcional electiva número 1. El paradigma ha cambiado en estos últimos años. Ya no nos centramos tanto en pacientes que son adultos jóvenes, sino que a ellos se suman una pléyade muy grande de personas que están ya en una edad de presbicia, en la que además, con el uso obligatorio de las máscaras que hemos tenido recientemente, ha despertado el interés por buscar alternativas funcionales a la dependencia de gafas multifocales. En este sentido, vamos a tener una primera sesión en la que vamos a abordar distintos temas que sin duda son del gran interés de todos.
Muy bien, y vamos a invitar ahora al doctor George Waring, que nos va a dar la keynote sobre the dysfunctional lens and presbyopia, pero antes vamos a oír un mensaje de la industria de parte de TEA.
En el cuidado del ojo seco, la bioprotección celular de la trealosa y la hidratación del ácido hialurónico se unen en un dúo avalado por estudios clínicos. Tealoz Duo ha demostrado que proporciona alivio inmediato de larga duración. Tealoz Duo, el dúo con ácido hialurónico y trealosa que hidrata y protege el ojo seco desde 2014. Tealoz Duo, la lágrima artificial líder en Europa avalada por estudios clínicos. TEA. Let's open our eyes.
Hi, it's Dr. George Waring from the Waring Vision Institute in Mount Pleasant, South Carolina, United States, and it's my distinct honor to deliver the keynote, The Dysfunctional Lens and Presbyopia at the RE Scientific 2022. These are my financial disclosures. I do have other disclosures that I have been called dysfunctional. You can just ask my wife. And I do have dysfunctional lenses, stage 1. I have very fond memories of my first RE in Alicante, Spain in the spring of 2011, where I actually performed my first live surgery ever. Here I am being interviewed by Dr. Alio, and you can just see how nervous I am by the look in my eyes. But all is well that ends well. Here we are with Dr. Alio outside the surgical observatory that he so warmly dedicated to my late father, who considered Dr. Alio to be one of his best friends, Dr. George Waring III. So we're speaking about presbyopia today. Over half of Asia is presbyopic as we speak. In the year 2020, there are over 2 billion presbyopes worldwide, with over 4 billion presbyopic eyes to help. So this is a wonderful opportunity. The age-old question has always been, do we help people on the cornea or the lens? Well, I'd like to credit Dr. Alia with the original description of optical lens dysfunction in 2005 in the Blue Journal of Ophthalmology. And as many of you know, Dr. Alio really is considered to be one of the most prolific clinician scientists in modern-day refractive surgery, and we are truly indebted to him for all of his contributions through the years, including the original description of optical lens dysfunction. But it was with Dan Dury, my mentor, and also Dr. Jason Stahl, also a mentor, and then with other contributions from Harvey Carter, that we started to look at this in a syndromic fashion, actually during my fellowship. And we went on to study this through the years with objective measurements and prospective interventional trials, and have published much on the subject matter. And as a result, the American Academy of Ophthalmology actually has now considered this to be a clinical entity, as you can see here. So what is the dysfunctional lens syndrome? Well, this is merely an attempt to characterize and standardize a triad of aging changes of the crystalline lens. So functionally presbyopia, and optically with higher order aberrations and lens opacities. And we've gone on to stage this over the years, with the first stage being presbyopia, the second stage being worsening presbyopia and manifest aberrations, and the third stage being a manifest cataract affecting daily activities. Here's some of the original publications back in 2007 from my wife, Dr. Carolina Rocha, looking at aberrations in the aging lens. So we have more and more ways we can address presbyopia depending on where it is occurring, meaning what stage of the dysfunctional lens syndrome is this occurring. And this is where we find the staging to be extraordinarily helpful, not only for an educational tool to our clients, but also to help us make good decisions on the best way to intervene, because we have so many different ways we can help people these days. So back in the original description from Dr. Alio's group, looked at densitometry and changes over a lifetime. And then we've gone on to publish over the years the double pass wavefront and light scatter as it falls on the retina with the aging lenses. And this actually gives an objective scatter index that we can correlate with the different stages of lens dysfunction. Furthermore, we validated the dysfunctional lens index with ray tracing aberrometry. Here in the center panel, we can subtract the internal aberrations and its contribution to the total optical performance. And we can look at this, perhaps correlate it with an opacity map as well. Now, we performed pilot prospective trials comparing optical performance independent of visual acuity and uncorrected visual acuity, which we also measured, to show that we can actually improve objective optical metrics looking at shine fluid densitometry and double pass wavefront relative to LASIK controls with refractive lens exchange. Again, in a prospective fashion, we could improve image quality that we could not do with LASIK. And there's a therapeutic advantage to lens replacement for dysfunctional lenses as well. Here's a patient in chronic subacute and subclinical angle closure living with high intraocular pressures with narrow angles, and we can see that with a refractive lens exchange, not only do we double the angle, we half the eye pressure. And we've gone on to look at this and present these findings over the years, again, and showing that we can therapeutically improve these patients in hyperopes with refractive lens exchange. This is our presbyopia management algorithm that's been proposed, again, completely dependent on the stage of lens dysfunction and refractive error, particularly as it relates to axial length. So the more hyperopic a patient is, the more likely we are to use a lens refractive approach. The more myopic somebody is, the more likely we are to do a corneal-based or a phakic intraocular lens. So what are the advantages of refractive lens exchange? Well, of course, it addresses presbyopia at the source, and that typically is the right thing to do, ladies and gentlemen, is to treat a problem at its source. It improves image quality where lens opacity exists, and we've shown this in prospective studies relative to LASIK controls. This obviates the need for future cataract surgery and therefore is truly anti-aging. It may be useful where corneal refractive procedures are not indicated, and it preserves or provides stereopsis. And maintenance of stereopsis, we believe, increases patient satisfaction, as shown by our mentor, Dan Dury, who demonstrated in his AOS thesis that as little as 0.75 diopters of anisometropia has a meaningful and statistically significant impact on stereo acuity. Well, we now have femtosecond lasers for lens surgery, so we can offer patients a laser procedure for lens replacement. And this is a pictogram in our textbook on corneal and lens-based refractive surgery, showing that we can actually perform lasers for custom lens replacement. So very LASIK-like, takes about the same amount of time as LASIK. We can perform both eyes on the same day like LASIK, and usually you're seeing well like within a day like LASIK, so very LASIK-like. But it has the additional advantages above and beyond LASIK, and that not only is it going to the source of the problem, but it also preserves stereopsis, it prevents aging, and also we get not only the distance corrected, but we get the near corrected. So refractive lens exchange should be considered for presbyopia treatment, but of course, careful risks and benefits should be considered, in particular with risk factors for retinal detachment and axial length. So I'd like to conclude with what we consider one of the most famous quotes of our time: why should the cornea suffer for the crimes of the lens? Thank you, Dr. Marshall, and thank you so much, Dr. Alio, for having us back to ARI and for your contributions to crystalline lens optical dysfunction.
Gran charla del doctor George Waring, cuarto. Vamos con la siguiente ponencia. El doctor Francesco Carones nos va a hablar sobre la cirugía de la presbicia en el plano presbita.
Thank you very much for the invitation to present on presbyopia surgery in the plano presbyopia. Here are my financial disclosures. And let's discuss the plano presbyopic patients, because these are the most difficult cases to deal with. These patients have excellent distance vision, they use glasses only for reading, and they are less likely to accept compromises as regards quality of vision and residual refractive error. However, these patients hate this behavior. I mean, they don't like to put the glasses on to read and take them off when seeing distance. The challenge with the plano presbyopic patients is to reduce intermediate and near spectacle dependence without compromises distance and quality of vision. We have different approaches involving either the cornea or the lens, and I'm going to discuss the one that I use the most in my practice. The procedure on the cornea may involve different strategies, but usually it's a single eye procedure. Some of these strategies have been used for a long time, some others have been completely abandoned. I'm going to focus on laser blended vision because this procedure in my practice is gaining consensus, and I had it done on my own eyes. There are many ways for performing Presby LASIK, and every single laser platform has its own, branded one. I'm going to discuss the laser blended vision that I can deliver with my platform, where the non-dominant eye is set slightly myopic, usually minus 1.5, but the eye is also induced with a spherical aberration for improving the performances for intermediate and near. Here you can see the corneal topography of an eye pre and post-operatively. You can appreciate the curvature steepening leading to the myopic outcome, but you can also appreciate the increased sphericity as regards the Q value and the negative spherical aberration that has been increased by the treatment. Who are the best candidates for this procedure? Well, emetropic patients are great candidates because they have a single eye treated with a very easy approach to deal with. However, these candidates must be perfect candidates for LASIK, so they must be suitable for a LASIK procedure. I like always to underline the importance of a contact lens trial because the procedure itself provides much better results than a monofocal contact lens trial. So if a patient is happy with a monofocal contact lens trial, this patient is going to get better results with laser blended vision. All these patients must be, instructed and trained to have realistic expectations because also laser blended vision, as well as all the other presbyopia correcting procedures, involve some sort of compromise. But here are the results that can be achieved distance vision is unchanged because we didn't treat the emmetropic dominant eye. As regards intermediate and near, you can see that patients have very good performances, and in most of the cases, these patients reach a complete spectacle independence. Let's move on now and discuss the lens approaches, where the surgery can be done on either on one or both eyes. And I'm not going to discuss presbyopia phakic IOS because worldwide there is still minimal experience regarding this. So I'm going more to focus on presbyopia correcting IOS and pharmacological therapy that may be a new frontier to approach. As regards presbyopia correcting IOS, we have two main categories: the increased range of focus IOS, where the dysphotopsia compromises are less than an issue, but these lenses provide only a partial range of vision, so they don't guarantee a full spectacle independence. If we want to have these patients reaching a full range of vision, we have to implant a full range of focus IOS like the trifocal or the hybrid, but we know that in this case, the compromises related to night dysphotopsia are more likely to be there. As regards the pharmacological therapy, there are two approaches, myotic agents and lens softening drops. Myopic agents are much more in the pipeline. The FDA approved already one of these drops, but there are at least 5 more different products that can be potentially used in future. Regarding the lens softening eye drops, well, there is only one company working on this, and the idea is very intriguing, and the study is still under investigation by the FDA. Here is my personal decision tree when treating a plano presbyope. Well, obviously there must be no lens changes, and in this case, the choice in between corneal surgery and presbyope correcting IOS goes on age and expectations. When patient is relatively younger and the expectation are not like to have an ultimate procedure, we may treat the patient with laser blended vision or monovision, but nowadays we treat many more patients with laser blended vision because results are really good. If a patient wants to have an ultimate surgery, we implant the non-diffractive increased range of focus IOLs when patients have night vision concerns. When a patient is really focused on spectacle independence, we prefer to implant a full range of focus like a trifocal IOL. So to conclude, when we are approaching corneal surgery, patient selection is critical. As I said, usually is one eye treated. Contact lenses trial is mandatory to drop out those patients who are less likely to have satisfactory results. And it is very important to give these patients a clear explanation and understanding of the benefits and compromises. It has to be said that far distance eyes has to be perfect to bring a satisfaction to these patients. When considering lens surgery that may be applied in one eye or both eyes, well, this approach in purely presbyopic plano patients is still controversial. The choice of the appropriate presbyopic correcting IOL is the key element to reach satisfaction, and the refractive target has to be achieved fully. So when implanting diffractive optics, the refractive target has to be plano. When we implant, non-diffractive optics and increased range of focus IOS, a mini monovision approach does not deteriorate distance vision significantly and improves performances as regards intermediate and near. So this is the approach that we like to consider. Thank you very much for your attention.
Thank you very much, Francesco. Great talk, and es perfecta para la charla que viene ahora a cargo de Ramón Ruiz Mesa, que es precisamente sobre estrategias avanzadas en monovisión. Ramón, tienes la palabra.
Hola, buenas tardes. Empezar agradeciendo a los doctores Salio su amable invitación a participar en este evento y felicitarlos por la calidad de la misma, a la cual ya nos tienen acostumbrados. Toca hablar sobre estrategia avanzada en monovisión. Sabemos que tenemos diferentes plataformas diferentes métodos y diferentes estratos córneo-cristalinos para intentar abordar el tratamiento de la presbicia. Empezando por el presbilásic, como resumen, podemos decir que una combinación de un perfil multiesférico que induce una cantidad controlada de aberraciones de alto orden, induciendo un residual refractivo miópico en el ojo no dominante. Hay varias propuestas: perfil multiesférico en ambos ojos, perfil multiesférico en ambos ojos añadiendo una micromonovisión adicional en el ojo no dominante, optar por un diferente perfil multiesférico en ambos ojos y, para finalizar, un perfil de ablación monofocal convencional en el ojo dominante y un multiesférico en el ojo no dominante. Como hemos visto en la diapositiva central, hay posibilidades de presbilásic periférico. Vamos a centrarnos ahora en el presbilásic central. Lo que hace es buscar una zona central en la córnea para la visión de cerca y una zona periférica circundante para la visión de lejos. Es un procedimiento, como podéis entender, muy pupilodependiente y una ablación mínima en el centro de la córnea, incluso en miopes. Como dispositivo a destacar, podemos destacar el Tecnolas Supracore y el Swing con su tecnología Presbimax. Supracore de Tecnolas, basado en el Oscar, tiene un perfil ablacional, como hemos dicho, de centro-cerca. Lo que intenta es corregir la visión de lejos, realizando una metropía con un target de menos 0,5 o emetropía, junto a un perfil de ablación central de 3 milímetros para una visión cercana de casi 1,5-1,75 dioptrías. Para los pacientes que exigen una buena visión de lejos, preferimos mantener el target de 0 en el ojo dominante o incluso en los dos ojos. La tecnología Presbimax con el dispositivo Swing nos va a dar también otro perfil ablacional centro-cerca, con un perfil biasférico, optimización asférica de la córnea central para visión cercana y pericentral para la lejana, una zona de transición con cambio gradual de la potencia que conecta la región de la córnea corregida para el lejos con la porción central corregida para el cerca, y siempre influenciado por la cantidad de adición. A mayor adición, más dominancia en el área central. Podemos determinar 3 prototipos: uno que enfoca más para monovisión, usando la visión cercana intentando que sea el principal gol; híbrido para toda la distancia, o bien monocular, en lo que buscamos una mejor visión de lejos. El presbilásic periférico ya probablemente no sea lo que más se utiliza hoy en día. Buscamos una región central para visión de lejos y un tratamiento en la córnea periférica para aumentar la profundidad de foco. Dado que el reflejo pupilar normal daría lugar a una pupila de entrada que podría no cubrir esa zona periférica, los resultados pueden que no sean tan fisiológicos como lo que hemos destacado antes con el presbilásic central. Tercera opción, utilizar el Laser Blended Vision. Como bien sabéis, un aumento en la profundidad de foco mediante la alteración controlada de la aberración esférica en ambos ojos con procedimiento Presbion de Zeiss, o bien un ajuste de la esfericidad solo en el ojo no dominante Custom Q cuando estamos hablando de Allegretto X500 de la casa Alco. Este cambio en la aberración esférica es lo suficientemente pequeño para evitar una disminución en la calidad visual, pero a la vez suficiente como para aumentar la profundidad de foco. Se puede realizar en cualquier perfil refractivo de paciente. La plataforma Presbion, ya sabéis, con el láser del 90, lo que intenta es combinar la monovisión e inducir una aberración esférica que conduzca a un aumento de la profundidad de foco. Se utilizan perfiles de ablación asféricas no lineales que incorporan un factor de compensación previa para poder controlar la inducción de la aberración esférica. Según Restein, en miope una aberración esférica de 0,25 micras va a inducir un aumento de la profundidad de enfoque de entre 0,5 y casi 0,7 dioptrías, y para el hipermétrope la inducción de una aberración esférica de menos 0,28 nos va a producir un aumento en la profundidad de enfoque de casi 0,75 dioptrías. Esto, si lo combinamos con la micromonovisión, nos va a facilitar que el cerebro fusione las dos imágenes con menor problema. Plataforma X500, Laser White Light. Lo que utilizamos son valores de Q negativos para la combinación de perfiles diferentes de ablación en cada ojo. Como planteamiento inicial, partimos que queremos llegar en los miopes a una Q de menos 0,8 a nivel bilateral. En hipermétrope, un poquito más reducido a menos 0,6. Trataremos solamente la Q si estamos hablando de presbitas jóvenes entre 40 y 45 e induciremos un poquito de refracción negativa, una micromonovisión en el ojo no dominante en el caso que el paciente tenga entre 45 y 50 años. Por supuesto, ajustando la de refracción en función de la Q adquirida. La idea clave de este procedimiento es una aproximación individualizada que consume menos tiempo en comparación con la que podemos tener con la ablación de frente de onda al estar basada en topografía. La ablación puede ser válida para miopes bajos, diría de menos de 2 o 3 dioptrías y astigmatismo miópico, produce amplias zonas evitando problemas de glare y de nublamiento nocturno y presenta una buena calidad de visión. Como perlas para todos los procedimientos de presbilásic, tenemos que tener en cuenta que determinar el eje del centrado es muy importante: la pupila, apex corneal, eje visual o eje óptico, evaluación previa de la dinámica pupilar y obviar este procedimiento como en cualquier cirugía refractiva buscando lente multifocal en pupilas que sean pequeñas o con mala dinámica, evaluar de qué Q provenimos, especialmente del tratamiento del Custom Q, por supuesto, mejor resultado en pacientes que tengan una presbicia incipiente, no tratar, al menos bajo mi punto de vista, en pacientes métropes por la pérdida de sensibilidad al contraste, evaluar siempre la película al animal, que no tengamos un resultado erróneo, no precisamente por un problema refractivo, sino por la superficie original, y explicar bien al paciente que son tratamientos que obviamente el protagonista de la presbicia es el cristalino y que tendrá un tiempo de caducidad y en el cual tenemos que estar preparados para en un futuro implantar una lente multifocal. Segundo bloque, lente monofocal avanzada. No vamos a centrar solamente en ella, no vamos a pasar de lentes multifocales a lentes fáquicas que hoy en día se están empezando a probar. Hay muchas lentes nuevas hoy en día, como lente monofocal, las tres principales son Enhance, Exopure y ENVI. También está Revolux de Sifi y la Imprex de Joya, con lo cual la amalgama de estas lentes también se están cada vez avanzando en el mercado. La primera, la que acuñó quizá probablemente la tecnología de monofocal plus, fue la Enhance, diseño óptico refractivo con una superficie anterior esférica de orden superior, mantiene como todas las lentes de la casa Technic menos 0,27 en negativo de aberración esférica. Estudios de Hoffman nos demuestran que mejora la agudeza visual intermedia si comparamos con una monofocal esférica, mientras que la sensibilidad del contraste es muy similar a la misma monofocal, incluso en condiciones fotópicas o mesópicas. La Isopure, bueno, nos ofrece una dioptría en el banco óptico de aumento prácticamente el 50% de la profundidad de enfoque si comparamos con su homónima, la esférica Micropure, y el aumento de profundidad de foco demostrado aquí que llega hasta 66 centímetros, que puede ser equivalente a 1,5 dioptrías. La LIO Ray 1 ENB de Reiner se utiliza siempre, incluye una aberración esférica positiva para mejorar la visión lejana, se utiliza siempre en el ojo no dominante, dejando en plano el ojo dominante, y según el fabricante nos ofrece un desplazamiento de una dioptría, produciendo por tanto una profundidad de foco de casi 2,25 en binocular. Aquí vemos como la lente monofocal de esta casa Reiner amplía el foco de visión a la distancia intermedia, superando la visión monofocal estándar y la monovisión estándar con lentes monofocales al uso. Para terminar, como ideas principales de las lentes monofocales, nos van a permitir una monovisión mejorada con un alto nivel de independencia de gafas para visión de lejos e intermedia. Por supuesto, mejora la visión intermedia si comparamos con lentes monofocales. En cambio, la calidad visual es muy similar a estas mismas lentes monofocales. Producen, por tanto, menos fenómenos fóticos, menos halos y glare, y puede ser una alternativa al explante en el caso de una mala experiencia con lente multifocal. Y, por supuesto, hoy en día quedan como una alternativa para aquellos pacientes que no precisen de una exquisita visión cercana, se mantengan con una buena visión intermedia y lejana, o para aquellos que, por supuesto, no estén indicados el introducir en el ojo una lente de alta tecnología modelo trifocal. Con esto es todo. Os querría agradecer la atención prestada y muchas gracias por la invitación y a seguir disfrutando del maravilloso congreso.
Muchas gracias, Ramón, y pasamos ahora a la siguiente presentación.
Sí, después de la completa, excelente charla del doctor Ramón Ruiz Mesa, pasamos con la doctora Margaret McDonald, que nos va a hablar sobre la terapia farmacológica en la presbicia.
Hi, I'm Marguerite McDonald, and it's my great pleasure to speak to you today about pharmaceutical therapy for presbyopia. These are my financial disclosures. There are two general categories for the drops to treat presbyopia: the pupil constricting agents and the lens softening agents. This shows the competitive landscape for presbyopia drops. The only one that has received FDA approval in the United States is Allergan's Vuity, which is 1.25% pilocarpine. But you see, as the companies move with their agents toward the center of the bullseye, they're closing in on FDA approval very quickly. Soon our patients will have choices: pupil modulation, combination drugs, and even perhaps lens softening agents. This is a close-up showing two new additions, two other candidates. Allergan has a second agent in phase 2. It is an alpha-2 agonist, a small molecule, and Glaukos has a pilocarpine transdermal cream. So interesting times ahead. So the most commonly used agent is pilocarpine. It's a cholinergic muscarinic receptor agonist. What's new is that the companies are using lower concentrations, much lower, very sophisticated delivery vehicles, and as you'll see, there are numerous clinical trials underway. So the first one to be approved, Allergan's Vuity, underwent 2 rigorous phase 3 clinical trials with 750 patients combined, and more patients in the treatment group versus the vehicle control group gained 3 or more lines of mesopic high contrast binocular distance corrected near visual acuity at 3 hours over 30 days of bilateral single dose use. There was no impact on distance vision. This shows that there's 6 hours duration of the drop when you are examining mesopic distance corrected near visual acuity. This graph shows that under photopic conditions, there is approximately 10 hours duration of good distance-corrected intermediate vision compared to vehicle. And it does not compromise distance vision. There was a trend for it to actually improve distance vision, but this was not statistically significant. So it was safe and well tolerated with a very low discontinuation rate. The big worry with pilocarpine is headaches. They were mostly mild and transient. Only 1.8% of participants had a moderate or severe headache, and no participant discontinued due to headache, and there were no retinal detachments. So another company, Orasis, is studying pilocarpine. Their agent is CSF1. A phase 2 study in 166 participants was completed in 2019, and they had good tolerability, excellent outcomes when dosed twice daily. Once again, no impact on distance or night vision, and 2 phase 3 studies in 600 patients have been completed. Pilocarpine is also being used by Eyenovia in their Microline product, which uses a microassay print technology, which is administered with a jet dispenser that sprays the drug at the eye. A phase 3 trial with 84 subjects had distance-corrected near acuity tested 2 hours after treatment with 1 or 2% pilo, showing a statistically significant portion of patients treated with active had a 3-line or more increase in distance-corrected near visual acuity versus placebo in low light 2 hours after treatment. A second phase 2 registration study is underway. Ocuphire is studying phentolamine, which is a non-selective alpha-1, alpha-2 adrenergic antagonist, alone under the trade name Nixol, and in combination with a morning after dose of low-dose pilocarpine, 0.4%. So Nixol at night and low-dose pilo in the morning. This combination synergistically activates the iris sphincter muscle and inhibits the iris dilator muscle. And by having very, very low concentrations of the active ingredients, this may decrease the likelihood of adverse events. And here you see phentolamine as a single drop taken at night. It's taken at night because it makes the eyes red for a few hours, and this has worn off by the time the subject wakens in the morning. So here you see phentolamine as a single drop on the left versus the kit of phentolamine at night with low-dose pilo in the morning. And certainly the low-dose pilo and phentolamine combo was statistically superior to phentolamine alone and low-dose pilo alone. 53% of patients received a 10-letter improvement or greater in distance-corrected near visual acuity at 12 hours with phentolamine alone versus 79% with the combination. But the company is moving forward with clinical trials in both categories. Vices Therapeutics has a combo of carbachol and brimonidine. This is the brainchild of Dr. Herbert Kaufman. We know carbachol is a much more potent cholinergic miotic than pilo, and combining it with brimonidine, which prevents pupillary dilation and may inhibit ciliary muscle contraction, this achieves synergistic effects and may decrease the severity of side effects. Also, brimonidine whitens the eyes, which may prevent the redness associated with all the miotics. Lens Therapeutics is the new name for presbyopia therapies. It's similar to Pilo. It's aceclidine, a parasympathomimic cholinergic muscarinic receptor agonist. And in PRX100, their product, it's being paired with tropicamide to induce strong meiosis without the associated accommodative blur, and the early results look very good. However, little has been released about the drug since 2018, and no additional studies have been registered with the FDA, though the company is reorganizing and moving forward under its new name, Lens Therapeutics. There are 2 more pupil-constricting agents about which little is known. Cadalian Therapeutics has Accustream, which is 1 or 2% Pilo in phase 2, and iFocus is from OSRX, and we're not really sure. It seems to be an investigative product with a miotic, an alpha-1 agonist, an H2 antagonist, and an NSAID. And there was a lens softening agent from Novartis. Clinical trials have stopped due to lack of positive results. So this is another glance at the competitive landscape, very exciting. And as the famous Yankee baseball player said, Yogi Berra, the future lies ahead. Thank you.
Muchas gracias por la charla de la doctora Margaret McDonald.
Bien, y me corresponde ahora presentar a mi compañero Miguel Maldonado, bien conocido por todos vosotros, que nos va a hablar de la función visual en conducción nocturna en el paciente con cristalino disfuncional, en íntima relación con la charla primera de esta sesión. Tienes la palabra.
Buenas tardes. Agradezco al profesor Jorge Alió su amable invitación a este excelente curso de cirugía refractiva, catarata y córnea. A continuación voy a hablar de la función visual en conducción nocturna en el paciente con síndrome de cristalino disfuncional. Dentro de la diferente gradación que puede tener este síndrome, mientras nadie duda que un grado 3 supone una catarata evidente con una alteración profunda en la visión en la que la indicación de cirugía del cristalino, en este caso de catarata, es incuestionable, el gran reto se sitúa en aquellos casos intermedios, es decir, estado 2, en el que el síndrome cristalino disfuncional arroja ciertas dudas acerca de si la indicación funcionalmente es adecuada o no. Pese que ha habido extensa literatura que ha investigado acerca de este síndrome en sus distintos estadios, falta evidencia acerca de la alteración funcional que se produce en estos pacientes, sobre todo en una situación tan común como es la de la conducción nocturna. Por lo tanto, el objetivo de este estudio fue el analizar el deslumbramiento en los pacientes con síndrome de cristalino disfuncional grado 2, realizando una prueba de conducción real, aparte de llevar a cabo una evaluación clínica con deslumbramiento dinámico, que esta fue realizada en el IOBA, y parte de cuyos resultados pues, se encuentran en este paper que pueden ver abajo a la derecha. Se contó con un grupo de casos, 40 sujetos mayores de 50 años, con facoesclerosis inicial bilateral, y un grupo de controles en los que la particularidad fue que su cristalino no presentaba ningún grado de opacidad. La facoesclerosis inicial se definió como aquellos casos en los que se presentaba algún score del LOX3 sin superar el grado 3 ni en su componente cortical, ni en su componente nuclear, ni subcapsular posterior. La prueba de conducción real se realizó en un circuito cerrado, en plena oscuridad. Las imágenes se muestran, no obstante, con luz para que puedan ser visionadas y reconocidas. A la derecha del arcén se situaron señales de alto contraste y bajo contraste, respectivamente 50% de contraste Weber y 37% de contraste Weber, que fue elegido al ser el mínimo exigido para conductores no profesionales en Alemania. Se enfrentó el conductor a una situación sin deslumbramiento, con deslumbramiento tipo halógeno y tipo xenón. Se trataba de conducir a 40 km por hora como velocidad constante y fácil de asumir, y tan pronto se reconocía la letra de alto o bajo contraste, se decía de tal manera que, gracias al sistema de equipamiento del vehículo de test, se podía sincronizar la grabación y la localización GPS de tal manera que se pudo calcular la distancia de reconocimiento real a la que el conductor dijo adecuadamente la letra. Por otro lado, la evaluación clínica con deslumbramiento dinámico se realizó en las instalaciones del IOBA. Consistió en una exploración de la función visual estándar con clasificación del componente cristaliniano según la LOX3, en la que la opacidad nuclear se gradó por el componente de opalescencia, puesto que es el que se ha demostrado que tiene más impacto que el color sobre la función visual. Adicionalmente, se pasó un test desarrollado por el propio IOBA, que se denomina AXEN, porque intenta reproducir el deslumbramiento dinámico de un coche que viene enfrente con faros halógenos, xenón, y se mide la sensibilidad al contraste, tomando como base un Peli Robson y recreando pues, la luminosidad propia de una conducción nocturna. La muestra alcanzó un total de 52 sujetos, 40 eran casos con distintos grados de opacidad no superior a LOX3 y hubo 12 controles. La edad de los pacientes con síndrome de disfunción del cristalino era una media de 59 años, personas con edad de presbicia clara, mientras que los controles, al no tener ningún componente de opacidad, eran claramente más jóvenes. Pese a que la agudeza visual corregida en ambos grupos no obtuvo diferencias estadísticamente significativas, como era de esperar, la sensibilidad contraste fotópica fue menor en el grupo de personas con síndrome cristalino disfuncional con respecto a los controles, así como también por la diferencia de edad, el tamaño pupilar fue menor en los casos que en los controles. Se muestra la distribución de la opacidad tanto en su componente cortical como nuclear, como subcapsular posterior en los casos. Los resultados en cuanto a la distancia de reconocimiento indicaron una disminución estadísticamente significativa en los casos con respecto a los controles de aproximadamente un 66% para las letras de alto contraste y de un 40% para las de bajo contraste. A su vez, cuando se compararon las distancias de reconocimiento sin deslumbramiento con deslumbramiento halógeno y deslumbramiento xenón, el de más alta intensidad, que fue el xenón, en los casos no produjo una disminución significativa de la distancia de reconocimiento, mientras que en los pacientes con síndrome de cristalino disfuncional sí. Cuando intentamos correlacionar el componente cristaliniano de opacidad con la disminución en las distancias de reconocimiento, encontramos que fue el componente cortical el que realmente mostró asociaciones estadísticamente significativas. En la prueba del IOBA-AXEM encontramos disminución estadísticamente significativa de la sensibilidad al contraste bajo todas las condiciones lumínicas, pero curiosamente no hubo correlación entre los componentes del cristalino, de opacidad cristaliniana, del LOX3, con todas las condiciones sin deslumbramiento y, sin embargo, con deslumbramiento tanto halógeno como xenón se pudieron establecer correlaciones estadísticamente significativas con la opacidad tanto de componente nuclear como cortical. Por último, el deslumbramiento incapacitante, es decir, la diferencia en la sensibilidad al contraste sin y con deslumbramiento, alcanzó una reducción estadísticamente significativa mayor en los casos de síndrome de cristalino disfuncional que en los controles, hallando correlaciones estadísticamente significativas para los componentes tanto nuclear como cortical. Como conclusiones, podemos afirmar que partiendo de agudezas visuales corregidas similares, en pacientes con síndrome de cristalino disfuncional grado 2, la distancia de reconocimiento de objetos de alto contraste y bajo contraste en condiciones de conducción mesópicas se halla profundamente afectada, mostrando reducciones de aproximadamente el 66 y 40% respectivamente respecto a los sujetos sin facoesclerosis. Por otro lado, la presencia de deslumbrantes de alta intensidad, particularmente tipo xenón, disminuyen la distancia de reconocimiento en sujetos con síndrome de cristalino disfuncional intermedio, mientras que la mantienen en pacientes sin facoesclerosis. El componente cortical es el que correlaciona más significativamente con la reducción de la distancia de reconocimiento en conducción nocturna para sujetos con síndrome cristalino disfuncional intermedio y opacidad con score inferior a 3 en la LOX3. Por último, la reducción en la sensibilidad al contraste por fuentes deslumbrantes, es decir, el deslumbramiento incapacitante, hay que señalar que es una medida más sensible que la sensibilidad al contraste fotópica o mesópica para la evaluación de los pacientes con síndrome de cristalino disfuncional intermedio o facoesclerosis inicial. Por lo tanto, todos estos datos debieran ser tenidos en cuenta y ayudar a los cirujanos a decidir correctamente el momento más adecuado para la cirugía del cristalino. Quiero agradecer a mis colaboradores, sin los cuales esta investigación no hubiera sido posible, así como a ustedes por su atención. Muchas gracias.
Magnífico, pues vamos ahora a pasar al debate, pero antes vamos a recibir un mensaje de la industria, en este caso de Zeiss. Muy bien, pues buenas tardes y gracias a todos los que estáis aquí, incluso desde lejos. Thank you, George, because finally you could connect with us in spite of the time difference, and Francesco, because you are here as well. So we shall try to get part of the presentation of the debate in English just for your information. First of all, thank you, George, because you saw beautiful pictures while of your stay here so many years ago that has a big memory for me. So thank you for that. Very good. And you know, the topic we are going to develop now is when is ethical to perform refractive lensectomy for presbyopia correction. So the topic is the ethics, the when to do it and when not to do it according with today's standard of ethical behavior. So I want to thank Dr. Maldonado. He will conduct the debate with me. And first of all, when do you think that is ethical? Starting with you.
Okay, for me the starting point should be that the indication should have a good benefit-risk ratio. And talking about risks in pseudophakia, the main one should be retinal concerns, and the incidence of retinal detachment has been really proven that depends primarily, number one, on vitreous loss. We cannot predict vitreous loss. Second, on axion length. We know how myopic the eye is, so myopic patients should be pulled apart from an elective clear lens extraction from my point of view. Third is age. Younger patients run a higher risk of retinal detachment than older patients. And last, male. Males have greater risk of retinal detachment than females. So taking all this into consideration, plus the nice indication Dr. George Waring depicted about a high hyperopic eye having a narrow anterior chamber and also narrow angles, all that should put us into a very different perspective from the high hyperop and the high myop. This should be the starting point for me from the discussion about ethical considerations in lens refractive exchange for presbyopia. I would like to hear your thoughts too.
I think that this is right, and we have different type of patients, because Francesco, you talk about the plantar presbyopia is perfect, because plantar presbyops have a relatively limited risk for retinal detachment. Is that correct?
That's correct, but this is also the patient who is most challenging in terms of, other potential side effects, because this patient may get one advantage, which is, improving intermediate and near without spectacles, but with the risk of compromising distance vision. So this is why, besides the ethical issue, there is also a matter related to the effect that our surgery may bring to these patients.
Right, and the myop is just the opposite. The myop has the clear risk for retinal detachment related basically to the presence or not of PVD, posterior vitreous detachment. So, Daniel Elias, you are intraocular refractive surgeon as well. What is the limit of ethics for myops, in your opinion? Under which conditions would you perform refractive lensectomy for a myop in presbyopic conditions, to correct presbyopia?
Good afternoon, Jorge. It's difficult to say a number because numbers depend on the eye. It's really different, really high myop with posterior vitreous detachment or not. But I think, I give you my numbers. I prefer to not do clear lens extraction or intraocular surgical refractive surgery in a patient younger than 50. Myop patients younger than 50. Let me put this number, but I think ethics is a different thing. Ethics just is to talk with the patient, transmit the proper and right information, and make a consent with that patient. Another thing is results, risks, etc. But I think it's ethic to talk in a patient 40 years old, 12 diopters myop, who has no other option than glasses because do not tolerate contact lenses, has no cataract, has no space for a phakic IOL, and at the end decide a surgery. Perhaps from an ophthalmological point of view, is not the best or is not correct, even correct, but could be ethical. Because if you explain exactly the risks, even retinal detachment or macular edema or residual refraction, if you explain properly the risks, you are clear in the information, the patient understands and accepts that information, that's ethic. That procedure is ethic, in my opinion. One thing is, from an exclusive... From an ophthalmological point of view, more than 10 diopters, more than 50 years old, etc. It's the numbers we manage everywhere. But I think ethics is something extra. It's something more, and perhaps we could go out to these pre-established limits, not being unethical.
Very good. And George, you pointed out in your presentation the hyperope with the anatomical considerations that the hyperope might have in certain conditions in order to really make a preferential use of refractive lensectomy. So, from your standards and in the United States, in which refractive lensectomy is very widely performed, which are the conditions for a hyperope to be accepted for presbyopia correction with refractive lensectomy if you have other alternatives in a given age, like in the 40s?
Let me begin by saying how excited I am to be here, and I have such fond memories of being with you in person in 2011, and hard to believe it was over a decade ago, and it was just one of the best experiences of my career, and so glad to be with my esteemed colleagues today. The hyperopic patient is an interesting refractive patient for a number of reasons. Number one, many of these patients are latent hyperopes, so they're more hyperopic than they let on. And that means that they've actually, in our way of thinking about this, is that's premature aging. So the latent hyperope, which many hyperopes are actually more hyperopic than you think. meaning that they've aged earlier because they're using their accommodation that still exists to see distance vision. So their asthenopic complaints of fatigue at the end of the day are because they don't have any accommodative reserve left for reading because they're using all their distance to accommodate to see distance. So this is, I think, a lesser understood aspect of refractive surgery in the hyperopic patient. And then, as we've pointed out in some of our research over the years, there's also, I think, the idea of subacute and angle closure that is much more insidious than many of us understand. I think this is something that also really deserves more attention because it can cause real long-term issues. And so not only is there a refractive quality of life improvement, but there is a therapeutic opportunity as well. And lastly, this is really where corneal refractive surgery does not shine. We do have amazing corneal refractive excimer platforms for hyperopic corrections, but these do optically not perform quite as well as the myopic ablations. And number two, they regress because of the role of the epithelium. And so you'll end up doing a lensectomy in these patients anyway. So now we've performed two procedures once they've regressed out of their hyperopic corrections over a few years. So there are a lot of considerations. Lastly, when we think about the ethics of this, the decision-making in our practice is the more hyperopic, the earlier we do lens intervention if they're interested and if we feel they're a candidate. Lastly, when we think of, again, from an ethical perspective, the hardest patients I operate on every week are the elderly, meaning the more mature the cataract, the looser the zonules, the drier their eyes, the more epithelial basement membrane dystrophy, the less their endothelial cell counts, the more mature their cataracts, the smaller their pupils, and all the other comorbidities. That's where the risk goes up. This is well established. The longer you wait, the risk goes up. So I do think that there is something to be considered for earlier intervention in general. So we have to consider this over a lifetime, and we have to carefully balance this with the risks of surgery that we have so eloquently discussed today.
Very good. And Ramon, you mentioned the corneal presbyopic procedures. They are not gaining popularity because, in my opinion, they are every technique is different and different softwares have been developed. For instance, PresbyMax, we have 3 generations of software, and so systematic studies have not been properly performed. But having said that, I use them. I use PresbyMax in about 1/4 of my patients, and they work. So for you, which is the indication as an alternative to refractive laser exchange of corneal presbyopic corrections today?
Okay, I have said before, the reason of the presbyopic is in the lens, not on the cornea. I understand that some of our colleagues, some surgeons, even my case years ago, working with EX500 of Alirito, I have performed this type of surgery for younger presbyopic patients between 40 until 48, 49 years old, usually more suitable for hyperopic patient. But if you are working with myopic patient and you have to explain absolutely, to explain that it's only a procedure for some time of the year, but at the end, they are going to wear glasses for near vision. And then we have to be ready to perform a lens exchange surgery with the same result that the patient was not operated on with laser.
Very good.
One question now for Dr. Teus. What would be your main indication for a myopic patient in their 50s, not yet with cataract? How do you manage your benefit-risk profile in these patients?
I have to say that a myopic patient of around 50 years old, unless he or she has a cataract, the crystal lens has to be preserved. The risk of retinal detachment is unacceptable, and to me, a poor candidate for a refractive lens exchange is a good candidate for a laser-based procedure in the cornea. So basically, unless if the range of the myopia is not very high, I would say that laser-induced monovision is the way to go. If the refractive error is very high, even in these cases, I'm reluctant to perform a refractive lens exchange, and I have done some cases, and they are pretty. The outcome has been pretty good. Even implanting aphakic IOLs, such as an ICL, looking for monovision works very well. And basically, my answer is I'll try to preserve the lens in a myope as long as possible.
Very good. I think that we are now over the time, and I think that we should close the session as well. I want to thank you for this opportunity to share with you all our opinions about the presbyopic refractive lensectomy. Indeed, we are, in my opinion, in a very adequate environment to define, because there is evidence in favor of not performing refractive lensectomy in bios when the patient has no PVD, especially when the age is below 55. In Harpros, we have other options like LASIK. LASIK performs beautifully because we have the induction negative spherical aberration. Presby-LASIK works as far as you select the patient, you look at the pupil, you look at the condition of the patient, you look at the ocular surface, and finally the metropic is a perfect case for this type of monovision strategies, as Francesco, because of his own experience, or because Miguel Teus, that I know that he had experience as well, has been for many, many years. And I think that with these ideas, I think that these reports that have been in the literature performing refractive laser exchange in hyperos with 3 diopters and in the 30s, late 30s, are inadequate and unethical. So thank you very much for your kind attention and to your participation here, Miguel, because as a good friend has been with us many years and in this session, and I think that the session is closed. So thank you very much indeed. Thank you.
Thank you.